I'm Tony from Mercy Perrysburg Family Medicine. As we do the third Wednesday of every month, give a talk on a different medical topic. Today, Dr. Casillas is supposed to be giving this talk in hearing and vision, but she's somewhere warmer. So I'm going to give this talk, so bear with me. Hearing and vision are two things that are very, very important to our stability, to our independence. Obviously, we have 5 different major senses, but hearing and vision are 2 of those that keep us probably the most safe and the most independent, because it makes us more cognizant of our surroundings and things like that. But as we all know, hearing and vision changes over time as we age. Men usually have greater hearing loss. All the women in the room probably already knew that. But it declines about a decibel per year. So I think this is a decent handout. If you look on page 2, you'll see that the average decibels for average hearing decibels is about 60. So it kind of goes down a little bit each year, particularly after the age of 60. But for the most part, a lot of these things in terms of hearing and vision are either underreported or undertreated. Part of that is because not all of us go for annual eye exams, and probably the majority of the people in this room have not had a hearing exam. And it's probably something that, again, in working with your primary care physician, particularly if you're age 65 and older, you start to do your Medicare annual wellness visits, it's something that should be talked about. Some insurances cover these things, some do not. I've learned, and I'm not endorsing this by any way, but Costco probably has the cheapest hearing exams and the cheapest access to anybody that might need something like hearing aids. So there's different types of hearing loss. The thing we tend to lose the most is conductive hearing loss. This is where sound can't get to the nerves. And you have on your front page there, it's a little bit fuzzy, but this is kind of what I always say. This is a model of the ear. So you have the outer ear, the middle ear, which has the hammer, anvil, stirrup. We all know that as from grade school and that. And then the inner ear, which has the cochlea. And the cochlea is the thing that probably is the thing that needs to get preserved the most, because this is what allows sound waves go into the cochlea, and that's what interprets signals to go to the brain of how we learn to hear. So you hear a lot of, you see, people with cochlear implants, and that's basically what that's all about. When we can't get, when we have this conductive hearing loss, it could be something that's a very quick fix. It could be, for most people, cerumen, which is just a fancy way of saying earwax. Some people just have earwax a lot more, build up a lot more quickly than others. Some of that actually is hereditary, and some of it might be just a personal hygiene issue. It might also be a medical issue. It's something that you can go to your primary care physician. You don't have to go to an ENT, an ear, nose, throat specialist, unless your primary care physician sends you to one to get that done. We can do it in the office. A lot of times there's just this contraption that pours like water into the ear and then kind of loosens things up. Sometimes there's some oils that'll loosen it up. There's something called Debrox that can also make it a lot. That's a prescription. That's something that can kind of soften it. The one thing that we hear a lot about is making sure that you use Q-tips in the right way, that you're just basically cleaning the outer part of the ear and a little bit in the middle, but not getting too far in there, because you can really jam that earwax in much tighter. You're going to have more problems. A lot of times people don't realize, and I've seen this more than once, when you have that earwax, something else might get trapped in there as well. And I've actually seen somebody get earwax pulled out and there was a ladybug encased inside of the, so you just don't know. But it's something that you want to make sure that you're just using Q-tips properly. There might also be a foreign body. If there is, like the one I just mentioned, then you have to go to an ENT and get those things taken out. The other thing that we want to make sure that we're taking care of, and again, it doesn't show it very well on your picture here, but there's a little piece right here. This is our tympanic membrane. So if you ever hear about, children getting tubes and that, I actually had a tube put in at about the age of 30, just because you have pressure buildup there and you need to be able to get that tube put in place. But that tube, that tympanic membrane may also end up with things like patches on it, these white patches, which will then decrease the amount or the ability of sound waves to get through to the cochlear. Those patches are almost like what we're going to talk about with glaucoma and, cataracts, where you get these patches on the eye. The same thing. If you have those patches on your eye, you're not going to see properly. If you have those patches on your tympanic membrane, you're not going to be able to hear properly. Otitis media, that's just another way of saying earaches or ear infections. And then some people have, and again, it could be a family history or an isolated incident of otosclerosis. This is where you have bone buildup. So again, the sound waves are not able to properly pass through the tympanic membrane to the cochlear, and things get a little jammed up there. The other thing that a lot of people tend to have, and this tends to be the most common thing, is sensory neural. The thing we often hear about the most is presbycusis. That's just fancy way of saying that we have hearing loss with aging. It's the most common cause of hearing loss. About 1 out of 3 people age 65 have this. Probably half the people by the age of 75 have this. It's the second most common illness next to arthritis in older adults. So this is where you have damage to the inner ear, and it could be over time for various things. It could be an occupational hazard. You might have done, you might have been in the military, or you might have been working construction. You might have gone to a heckle of a lot of concerts and did not have proper hearing protection. But this is something that is progressive and irreversible. Probably the number one thing, and I have this as well with presbycusis, is you're not able to hear high-pitched volumes. So my wife will say, did you hear the oven coming on and it whistling, or did you hear that bird go by? And I'm like, no. So those high-pitched sounds, you're really not in tune with. Again, it could be genetic, it could be environmental exposure, but there are treatments for it. Probably the thing that is most commonly used as a treatment would be hearing aids. Let me find out where I'm at here. Toxics. I like this graph on the back about how loud is too loud, and I apologize for it not coming out very clear, but it just shows how, like I said, normal decibels is 60. If you're in heavy traffic, it's 85. And then if it goes on to, playing loud music and plane taking off, things like that. So you can just kind of guess or see how much more significant decibels can be compared to average hearing, and how over a prolonged period of time that could potentially have, cause problems. The next problem related to hearing loss would be toxic exposure. This is basically caused by certain types of drugs, diuretics, solicitates, which is basically, it's found in plants and certain types of medicines like aspirin. It says on there aminoglycosides. That's just fancy way of saying antibiotics. Certain biotics that are used to treat bacterial infections. And then I should just keep my glasses on. People that have chemotherapy. So probably the way that a lot of these people are on these long-term medicines are potential to have hearing loss. The only way you're going to potentially reverse that is to stop those treatments. You might have heard of Meniere's disease. That is something where you have one-sided hearing loss and you have a lot of fullness and ringing in the ears. You might also be subjected to vertigo. Vertigo is just the same fancy way of saying people are having dizziness. Sometimes you might even get this as well if you're standing up too quickly. That kind of goes along with what we call orthostatic hypertension or hypotension, but also it could be a potential problem with your ears. So this is something that can be potentially treated with the low salt diet. You might have to go for something called vestibular therapy. It's almost like occupational therapy or outpatient or physical therapy, occupational therapy. But they can work with you on trying to retrain your brain to cut down on that type of hearing loss. This is one situation where hearing aids are not as effective. And then you also have things like idiopathic sudden sensory neural hearing loss. This is something that happens very quickly. If you have sudden hearing loss, like within, a couple of 3 days, this definitely requires some type of emergent evaluation to get to probably an ENT. And yes.
Is there anything that measures the decibels? Like on your TV, it just says the volume's 1, 2, 3, 4, 5. Is there anything that can tell you?
Yes, there is a fancy machine. I don't think you want to order it on Amazon because I've seen it actually. I cannot think of the name off the top of my head. I apologize, but there is something that does measure decibels. I always measure decibels by how loud my television is versus when I used to go visit my mother and how loud her television is. It always, you can tell that's a perfect example. You could tell of hearing loss as people get older because you go to my father-in-law is the same way. His television is just so loud. But there are things that you can do. I have to look it up on my phone.
There's probably an app for that, right?
I think my Apple Watch will record decibels. This is what it's looking like. This says like this conversation is about 70 decibels right now.
I'm a loudspeaker. I apologize.
Gotta project, but I'm not sure. There's probably an app on your phone that will do
There
that.
probably is an app, and I never even thought that there was a way to measure decibels on your smartwatch.
Yeah.
I don't carry one, so I don't know. I'm a very simplistic person, but that's a very good question, just to know that.
Also, you mentioned ringing in the ears. I do have tinnitus. Is that?
I did not mention tinnitus, but that's certainly the ringing in the ears, and that kind of goes along with the Meniere's disease. Tinnitus and Meniere's disease kind of go hand in hand. So you do have that ringing in the ears. The question becomes, is it something that's constant for someone, or is it something that you notice at certain parts of the day? Have you ever had a hearing exam? I hate to call you out.
Yes.
Okay. So
It's whatever my wife's voice is, frequency. I
Mhm.
can't hear that.
I think I said that in the very, very beginning of my talk here.
Spousal deafness.
So, but again, some people can tolerate that, And some people, it might be a little bit more significant that they need to, get that evaluated by an ENT. So,
I was trying to search a machine and it just comes up with decibel.
yeah, I cannot think of the name of it off the top, but I wasn't prepared to give this talk 100%, so I apologize. The next thing is vision. Obviously, some people say, well, if I had to flip a coin between hearing and vision, I probably would protect my vision more than I protect my hearing, because it certainly, a lot of people consider it the most important of the senses. But our vision reduces by about a third after the age of 65. The Ophthalmology Society recommends that we get a vision exam done every year, particularly if you're a diabetic. Over the age of 65, you should be getting your Medicare annual wellness exam with your primary care physician. They should be asking you at that time, have you had an eye exam done in the last year? And they'll need to know where you got that vision exam, because they need to get a copy of that report put into your electronic health record, because that helps them to stay current and up to date with the Medicare standards. So if you haven't had that, probably something you should be hearing from. There's different types of vision loss. Macular degeneration is probably the most common. This is where we have loss of our central vision. And on the page behind that, I think there's a really good thing that just shows you the difference between cataracts, macular degeneration, diabetic nephropathy, glaucoma. So you can kind of see how they all compare and contrast to one another there. But the risk factors are age, family, hypertension, smoking. Hypertension and smoking are probably the two biggest things, if it's not genetic for you, that are going to cause risk. So you have blurred vision. You have a distorted Amsler grid test. I gave you, actually Dr. Casillas gave you, on the very last page. You can do one for yourself, but you can see here what a normal grid looks like versus doing it for yourself, how a distorted Amsler grid looks like when you are looking at your vision. And if you start to see that distorted, I would probably look to get in to see somebody else, because it doesn't cause total blindness, macular degeneration, but it does, hamper our ability to read, particularly see things when the room's a little bit darker. And we want to make sure that, like I said, we're getting that eye exam every year, that it's not just reading, which looks better, A or B, 1 or 2. It's getting that dilation of our pupils done, and making sure that we're, have good healthy habits of not smoking and, paying attention to our blood pressure and things like that. Treatment for this can be laser. Some people use glasses or modifiers. The other thing is, and this is where we were talking about vitamins and supplements, there are things out there called AREDS. So you'll see, if you're watching Let's Make a Deal or The Price is Right, if anybody's home during the day watching television, you're going to see a lot of AREDS on there. And again, do I know the difference between what Walmart sells and what Kroger sells, in their aisle? No, but I would encourage you to have that conversation with your optometrist or ophthalmologist. I take something called lutein. It's just an eye vitamin supplement. It is something that they have like 6 milligrams, and then they have 20 milligrams, but then they, can add some other things. It's about having a good conversation with your care provider to make sure that you are using the right one, using the right dose, and kind of going from there. Thank you.
I'm sorry.
You're fine.
I was flabbergasted that my eye doctor said he didn't think eye vitamins do anything.
And you know what? I'm not shocked, because there are a lot of pharmacists out there that will say that. and there are a lot of optometrists and ophthalmologists that are out there that will say that, but it just depends on who the provider is. And I guess I would say, where is that literature coming from? It's kind of like, I don't want to get controversial here, but it's kind of like vaccinations. Some people say they work. Some people say they don't work. So where are you getting your information from? And it might be a conversation you have with your pharmacist. It might be a conversation you have with your primary care physician. That you say, my eye doctor said, they may not necessarily. What is your take? And hopefully they are giving you an evidence-based answer as to why they say yay or nay.
There probably haven't been first-rate tests, like double-blind tests on that.
I can tell you there have been. But, oh, that's 1,000%. However, it depends on who and I don't want to go down a rabbit hole here, but it depends on who was part of the study, who was ruled in, who was ruled out. So again, ARIDS are something that can certainly be beneficial. However, what may work for you may not work for me, and that might be part of why they're saying that as well.
That's true for everybody. Peanuts.
Exactly.
Yeah.
Exactly.
Yeah, so how do you spell ARIDS?
It's right on your paper, AREDS. Yep.
Thank you.
Glaucoma is the next one. So this is where we lose use of our optic nerve, and we start to lose our peripheral vision, and it starts out here, and then kind of glaucoma, you eventually lose going toward the center of the eye. It's the most common cause of vision loss in African Americans. This is more, I tend to see this more as with family history, a high degree of people with myopia. That's just a fancy way of saying farsightedness. I'm sorry, nearsightedness. You can't see far away. Lost my train of thought here. People that have hypertension and diabetes, again, you typically don't see it in the early stages, but eventually you'll see this visual field loss. You'll get blurry vision. These people need to get probably their eyes examined a little bit more frequently. There are treatments like topical medications. They're all listed here, and then for some people it's surgery. Cataracts, this is where you have an opaque lens, and your visual function just isn't the same as it was. This tends to cause most common cause of blindness worldwide, particularly in people over the age of 75. The risk factors for this are age and UV exposure. So if you are somebody that's been out in the sun a lot, that you didn't wear sunglasses, that you really didn't take care of yourself in your younger years, it's going to catch up. This is where you get a little bit of a halo effect. You can see that on the next page. But it's something that obviously we've heard a lot more advancements in cataract surgery, where they can help with that to improve people's vision. Diabetic retinopathy is the last one I'm going to mention real quick. And this is destruction of the macula associated with diabetes. So you can see that it's a lot more significant. It's the leading cause of blindness in Americans. Risk factors is duration of diabetes, age of diagnosis, and I would say to some extent compliance. Did you catch this early? Are you doing what's necessary to take care of things? Now, there are some people that are extremely compliant and still continue to have diabetic retinopathy. But again, blurry vision, fluctuating in vision. You see floaters. I'm going to just say this with caution. Just because you've had a floater or two doesn't mean you have diabetes. It's something that I really didn't talk about much here, but it is something that is possible and, can come and go. You can have a floater and then not have any for a significant period of time. The other thing that I didn't mention related to vision is people that have certain occupations or are at home for long periods of time that are on their phone or on the computer. You got a lot of eye strain. You're gonna have some distorted vision at times. You're gonna have some floaters at times. These are just things that are people who just constantly fixated on a screen that aren't blinking and, you know, kind of taking some, I say what I call vision wellness, you know, taking some breaks and things like that. But treatment for diabetic retinopathy, like I said, tend to be more, I would say, surgery related, but for the most part, I don't want to run over just a quick overview of hearing and vision loss. So, any other quick questions? Yes.
What's stigmatism?
Stigmatism, more where trying to,
I think it's when an eye isn't very round, so that it isn't.
so
Okay,
it-
that's what I thought.
you
I
have the
read.
curvature of your lens, and if it isn't, you know, symmetrical, if it, or I should say, if it's not, if it isn't completely curved, then you're gonna have the changes in your vision.
So it's
Another
something that
thing
you
we-
could grow
yeah.
into or out of?
You potentially can, absolutely.
Okay,
Particularly if, because the eye is a little weak, you tend to see stigmatism. I'd say a lot in younger children, but if they get corrective wear and
I was
are
wondering.
being compliant, you can kind of strengthen the eye and,
okay,
you know, change that a little bit.
that answered it, thank you.
So, and I didn't mention about diplopia, which is double vision as well. You might have seen that in your, thing as well. Yes,
Do you know anything about narrow angle glaucoma?
I do not. I apologize. If that's what you specifically came to hear,
Yeah,
Dr.
is it-
Casillas probably could have answered that one.
How do you spell it?
Thanks for your time.
How do you
Appreciate
spell
it.
that doctor's name?
Casillas,
Yeah.
Casillas.
What? LL, what?
A-S, Casillas.
LLAS.
Casillas. She's a family medicine physician, but she, you
Oh,
know,
she's not an eye doctor?
no, she's not, no. I don't know, even though our office is in, Wood County, down toward Levis Commons, I'm not familiar with who the, and again, the difference is, are you seeing, if you're going just for a regular, to get glasses, go to an optometrist. If you're talking about things like you just mentioned, you definitely want to make sure you're getting to an ophthalmologist.
Yeah.
So,
I've talked to two of them already about, I took medicine that said it could cause cataracts or glaucoma,
mhm,
but they said, oh no, hardly anybody gets that, but it's listed. I started having eye issues and then they told me I have narrow angles.
mhm.
So one of the things they do is do laser holes, permanent holes in your irises to relieve some of that pressure. So that's why I was getting second opinions to,
And you're absolutely right. I would be, if I'm looking at a diagnosis that I'm not familiar with, and I'm looking at a procedure, potential procedure that I'm not familiar with, I'd be getting second opinions as well. Just because it's our vision. It is the single most thing that keeps us independent. And I can't imagine life with the distorted, you know, vision for the rest of my life. So I don't blame you for due
Yeah.
diligence and.
my friends are like 3 and 4 opinions, but. but
It's
so far
easy to
they're
say
saying-
that,
Yeah,
but what happens when you get yet one more